Hello and welcome to this case study presentation. Today we will discuss Sam. Sam is 21 years old. He's normally fit and well with no previous medical conditions. He's currently away at home at university studying. Sam comes to accident and emergency after being advised by his uni friends that he seems to be unwell. When Sam sees the triage nurse, he reports that he's had symptoms over the last few weeks of going to the toilet more often, drinking more but still having an incredible thirst, feeling a lot more tired than usual, and he's also lost some weight. The nurse performs vital signs, observations, and identifies a new score of 0. So is there anything else that the nurse should check with Sam? Blood glucose and ketone levels would be really important. Sam may have some stable observations, however, he has symptoms that are a strong indication to suspect type 1 diabetes. Therefore, his blood glucose and ketone levels should be checked to exclude or give a diagnosis. When checked, Sam's blood glucose level is 20.9 millimoles a litre, which is a strong indicator of diabetes. His ketone levels read 1.1, which also indicates that he actually has type 1 diabetes. If appropriate care is not given, Sam's ketone levels will rise, and he would then need to remain in hospital and be started on an intravenous insulin infusion in order to prevent him going into diabetic ketoacidosis. The triage nurse promptly refers Sam to the hospital diabetes team. Sam meets a diabetes specialist nurse who firstly requests 4 units of rapid-acting insulin to be administered, as Sam's glucose levels are above 18 millimoles a mole. The diabetes specialist nurse then informs Sam that he has type 1 diabetes and that this is an autoimmune condition where the insulin-producing cells in the pancreas are destroyed. Sam is understandably quite shocked to hear his diagnosis and asks what he needs to do to manage his condition. What do you think Sam needs to be educated on? Insulin therapy is essential for all people with type 1 diabetes. Sam will need to have an insulin regime that helps to stabilise his blood glucose levels and fits in with his lifestyle. There are many different types of insulin regimes available, but people with type 1 diabetes will most commonly have rapid-acting insulin to cover their meals, such as Nova Rapid, and long-acting insulin that continuously works in the background to cover their basal requirements, such as Levemir. Sam also needs to be educated about blood glucose monitoring. He will need to check his blood glucose levels before each meal and bedtime. This will show if he's on the right dose of insulin. Sam and all people with type 1 diabetes require insulin injections, and it is important that Sam is given education on how to administer it correctly and discussing such things as checking that the insulin is in date and how to store it, the rotation of injection sites, how to give an injection, how to use the pen device that he will be using, and also, more importantly, how to dispose of the sharps that he uses, which is the needle on the pen. Sam also needs to understand about low blood glucose levels, hypoglycemia, which is defined as a blood glucose level less than 4 millimoles a litre. Sam needs to be educated about the signs and symptoms of a hypoglycemic episode. These include sweating, hunger, dizziness and shaking. If they should occur, he needs to know how to treat them and factors which increase his risk of having a low glucose reading, such as exercise or the wrong amount of insulin. The diabetes specialist nurse should also discuss driving with Sam, and he needs to be informed that his glucose levels need to be checked before driving to ensure that his level is above 5 before he drives. He also would then need to check every 2 hours whilst driving. When people with type 1 diabetes are unwell, insulin can become less effective, causing high glucose levels even when they are not eating. Sam should be made aware of sick day rules, which will help him manage his glucose levels during these times. During illness, it is essential that Sam never omits his background insulin, tests his blood and ketone levels every 2 to 4 hours, and then adjusts his insulin doses according to the sick day rule advice. Once Sam has received his education and his observations are stable, he is free to be discharged. Before Sam leaves, it is important that he has the relevant information leaflets and knowledge and emergency contact numbers should he need advice prior to him being contacted by the diabetes team, who will also follow him up, manage him and support him with his type 1 needs, giving him the appropriate education and support. He will also be followed up by his GP and receive an annual review each year to check his blood pressure, his eyes, his feet, and any bloods that need to be carried out. 6 months later, after receiving support from the hospital diabetes team, Sam was referred to his local structured education programme called Daphne. This has given him knowledge and confidence to manage his diabetes more independently. This concludes the end of this animated case study.
Welcome to this essential guide into type 1 diabetes, which explores the care required during diagnosis and ongoing beyond. In this presentation, we will discuss the following. Diabetes affects approximately 4.7 million people in the UK. About 90% have type 2 diabetes, about 8% have type 1 diabetes, and about 2% have other rarer types of diabetes. Type 1 diabetes is an autoimmune condition where the body destroys the insulin-producing cells within the pancreas, causing an absence of insulin. People with type 1 diabetes are able to break down carbohydrates into glucose, but are unable to enter the glucose into cells and be used for energy, as there is no insulin being produced. Type 1 diabetes more commonly occurs in children and adolescents, but it can occur in adults. Unlike type 2 diabetes, there is no known exact cause for type 1 diabetes. The destruction of the insulin-producing cells causes blood glucose levels to rise. This can lead to the development of signs and symptoms such as increased urination, extreme thirst, fatigue, thrush, blurred vision, and unexplained weight loss. Healthcare professionals need to be alert to these symptoms and suspect diabetes if any are presented. One good method of staying alert is remembering the 4 T's. Toilet means going to the toilet more often to urinate. Thirst means drinking more and being extremely thirsty. Tired means feeling more fatigued than usual, and thinner means losing weight or appearing thinner than usual. If a person presents with symptoms, it is essential to check their blood glucose level. If the level results is more than 11 millimoles, this indicates diabetes. If the result comes back 11.0 millimoles or less, then it is important not to rule out diabetes and consider performing an alternative test, such as a fasting plasma glucose or an oral glucose tolerance test. Ketones should also be checked either by blood or urine. Ketones are produced by the liver to help break down fats for energy. High levels of ketones in the blood increases the risk of developing diabetic ketoacidosis, which is a life-threatening condition. The table on the slide shows ketone level ranges and its indicative risk for DKA. If a blood ketone level is 3 or more, this indicates DKA, and the person requires urgent hospital support. Diagnosing type 1 diabetes is urgent. The person must start insulin as soon as possible and be referred to the hospital diabetes specialist team straight away, so that they can confirm the diagnosis and provide immediate support to prevent glucose and ketone levels rising further. At the time of diagnosis, or when clinically stable, the diabetes team should develop an individualized plan with the patient for their early care. Education should also be provided, which includes informing the patient that they have type 1 diabetes and helping them to understand what it is. Ensure to identify the person's prior knowledge and present emotional state to determine the pace of the education. So we will now go through the educational aspects. Insulin therapy is essential for all people with type 1 diabetes. The person will need to have an insulin regimen that helps to optimize their blood glucose levels. NICE recommends a multiple injection basal bolus regime. consisting of long-acting insulin and rapid-acting insulin. Long-acting insulin has no peak of activity and works continuously in the background. Twice-daily Levemir is usually first choice. There are alternatives such as Lantus, Abasaglar, or once-daily Tresiba. Rapid-acting insulin covers meals and are ideally administered 15 minutes before eating. A rapid-acting analogue such as Novorapid, Humalog, and Fiasp should be considered first. If an adult has a strong preference for an alternative mealtime insulin, it is important to respect their wishes and offer the preferred insulin. If a basal bolus regimen is not suitable or possible, then a twice-daily mixed insulin can be chosen, such as Novamix 30. Self-monitoring of blood glucose levels is essential for the management of type 1 diabetes. The person needs to be educated on how to measure their blood glucose level and advise them to test at least 4 times a day, including before each meal and before bed. Ensure to set targets, as this helps to identify if the person is on the right insulin type, regimen, and dose. Ideally, the person should aim for blood glucose levels between 5 to 7 upon waking, 4 to 7 before meals, and at other times of the day. Bedtime target glucose levels should be set and agreed with the individual patient to avoid nighttime hypos. However, consider individualizing the daytime glucose level targets based on factors such as age, complications, and other medical conditions. It is also important for the person to not only understand how to perform a blood glucose test, but also how to interpret the result and know what action to take. Hypoglycemia is defined as a blood glucose level less than 4 millimoles, and something which on average a person with type 1 diabetes experiences twice a week. Hypos are either mild, moderate, or severe, and it is important for the person to understand the symptoms that can occur and how to treat an episode. For full information about hypoglycemia, please listen to the discussion following this presentation. The DVLA have strict driving regulations for people with diabetes. If a person with type 1 diabetes drives, they should check their glucose level less than 2 hours before the start of their first journey, then every 2 hours. The glucose level must be above 5 millimoles in order to drive. If a hypo develops whilst driving, the person should stop the vehicle safely as soon as possible, remove the keys from the ignition, move from the driver's seat if safe to do so, and then treat the hypo. Once the hypo has been treated and glucose levels are above 4 millimoles, wait a further 45 minutes, then check the glucose level to ensure it is above 5 to drive. Also, advise the person to have their blood glucose testing equipment and emergency supply of quick-acting carbohydrates with them during any journey, just in case. When people with type 1 diabetes are unwell, insulin becomes less effective, causing high glucose levels, even when not eating. Whilst unwell, the person should rest, drink plenty of sugar-free fluids, control symptoms, for example, taking painkillers for a high temperature, and try to eat as normal as possible. It is also important for the person to never omit their usual insulin doses, test blood glucose and ketone levels regularly, and adjust insulin doses appropriately. Also advise the person to obtain urgent medical attention if they experience nausea or vomiting, acute abdominal pain, or uncontrolled glucose or ketone levels. People with type 1 diabetes need to be aware of sick day rules, which help to manage glucose and ketone levels during illness. Sick day rules recommend glucose and ketone levels to be checked every 4 hours, even during the night. When blood glucose levels go above 11 millimoles, additional insulin is required in accordance with the ketone level. If the blood ketone level is below 1.5 millimoles, then additional insulin should be administered to each normal dose as seen in the left green box. If, however, the ketone level is between 1.5 to 3 millimoles, then 10% of the person's insulin total daily dose should be given with rapid or mixed insulin every 2 hours, as seen in the middle green box. Glucose and ketone levels also need to be monitored more frequently. If the ketone level rises above 3 millimoles, then 20% of the person's insulin total daily dose should be given. However, it is recommended for the person to be in hospital at this stage as they may be in DKA. Ongoing support is essential. Provide the person with contact details to essential services such as a diabetes helpline. Also provide information of next appointments and follow-ups and create a jointly agreed individual care plan. The care plan should contain information about insulin therapy, self-monitoring of blood glucose levels, avoiding hypoglycemia, pregnancy and family planning advice for women of childbearing potential, cardiovascular risk monitoring and management, and monitoring and management of complications. The care plan should be reviewed and modified every few weeks following diagnosis, then at least once per year. Managing type 1 diabetes requires skills to cope with the daily demands of the condition. To help, the person should be offered a structured education program of proven benefit, such as DAPHNE, which stands for Dose Adjustment for Normal Eating. The program should be offered 6 to 12 months after diagnosis, but can be offered after a year at a clinically appropriate time. The aim of the education program is to improve overall glycemic control, minimize hypoglycemia, and improve quality of life. It achieves this by teaching the use of carbohydrate counting and flexible insulin therapy in order to optimize glycemic control. To conclude this presentation, it is important that people with type 1 diabetes are provided with up-to-date information about diabetes support groups both locally and nationally, and how to contact them. A great place to start is Diabetes UK, who have a list of diabetes support groups within a person's local area. Go to www.diabetes.org.uk for further information. So I hope you found the presentation useful, and up next is a discussion about hypoglycemia. Thank you for listening.
Hello and welcome. We hope you found the animated case study about Sam a useful introduction into type 1 diabetes. Next is this discussion, which is about hypoglycemia. So let's kick things off by understanding what we mean by hypoglycemia. Rachel, would you like to explain?
Thank you, James. So hypoglycemia means low levels of glucose in the blood. It's defined when that level drops below 4 millimoles per litre on a capillary blood glucose test. On average, people with type 1 diabetes experience around 2 episodes of low glucose readings per week, and these can be caused by many different factors. Normally, too much insulin, inadequate blood glucose monitoring, so they're not sure what's going on, injection technique problems, increased physical activity, or alcohol consumption. It's important to identify the cause of the hypo to try and support the individual to make suitable changes in order to reduce this risk of it occurring again. So let's now discuss the signs and symptoms that a person with type 1 diabetes may experience during a hypoglycemic episode. James, would you like to take the lead?
Yeah, sure. So when a person is in a hypo, they can first experience mild or also known as autonomic symptoms. So this could be things such as sweating, palpitations, shaking, and hunger. And the person should be responsive to those symptoms and be able to self-treat the episode. However, mild symptoms, if they're not identified or treated, then moderate or neuroglycopenic symptoms can develop. And these are things such as confusion, drowsiness, and they can progress to things such as seizures or a loss of consciousness. So if the person develops really bad symptoms and is unable to treat their hypo themselves, requires assistance, this is defined as a severe episode.
So it's important to be aware of recurrent and frequent episodes of hypoglycemia over time, as this can increase the risk of hypo unawareness. So this is when a person has reduced awareness of those symptoms of a low glucose reading that then causes an increased risk in the recurrent episodes occurring. One method for assessing awareness is through the use of the GOLD score, which asks the person if they know when their hypos are commencing and rate their level of awareness between 1 and 7. 1 indicates that the person is always aware of when their glucose levels are dropping low and they're going into a hypo, and 7 indicates when they are never aware. If a patient scores 4 or more, it indicates impaired awareness of hypoglycemia, and short-term focus of avoiding hypoglycemia will eventually help them reverse this unawareness.
Thanks for that, Rachel. So let's discuss about managing hypoglycemia. So it's important to understand how to treat a hypo, as this is the only way to raise those glucose levels. If the person is able to swallow, then they should take 15 to 20 grams of quick-acting carbohydrates. So this could be something like 4 large jelly beans, 150 to 200 mils of natural fruit juice, or 5 to 7 glucose tablets, or 1.5 to 2 tubes of glucose gel. And that needs to be rubbed in between the teeth and gums and not swallowed. It needs to be absorbed. Some people may have heard of Mars bars or chocolate as an effective way of treating a hypo, but that is not suitable, as chocolate contains fat, which actually slows down the rate in which carbohydrate is broken down into glucose. So that will actually cause the hypo to take longer to be treated.
That's a really important point, James. I think the other thing to also remember is that when we advise patients on their hypo treatment, is actually to avoid over-treating by taking too much of the quick carbohydrates. And this can be really difficult for them not to do, especially if they're feeling very hungry or anxious when these low glucose events are occurring. And over-treating that glucose level can then actually lead them to then have a high glucose reading. And the best ways to avoid this for the patient is to pick their preferred treatment so they know the measured quantity that they should be having, and therefore they don't over-treat.
That's a really good point, actually. So thanks for that, Rach. So once a treatment has been given, then the person should wait between 10 to 15 minutes to allow the glucose levels to rise. Then the person needs to recheck their glucose levels to see if the hypo has actually resolved and their levels have gone above 4 millimoles. So if the blood glucose level remains below 4 millimoles, then the person obviously is still in a hypo, and they should treat their hypo again with another lot of quick-acting carbohydrates. But if the level does go above 4, therefore the hypo episode has been treated, they should then have a long-acting carbohydrate. And this could be something such as a slice of toast or a banana. And that allows the glucose to be stored, ready for when it's needed as well. So once a hypo has occurred and been treated, the person should, and it's important to be, reviewed by the GP or local diabetes team. And that's in order to help reduce the risk of further episode occurring, such as they may need to reduce doses of insulin or certain diabetes medication as well, like glipizide.
I think that's really important, James. I think the other thing to also remember is that actually if they're unable to resolve that hypoglycemic episode themselves, that they actually call for emergency support. So what we recommend is that people can carry out 3 cycles of the quick-acting carbohydrate and check that that glucose level is becoming above 4. If it's not becoming above 4, it has not resolved. So they need to then call the emergency services to help them out. The other side of that is that the individual is unable to swallow, So they're unable to actually take any of the oral hypoglycemic episodes, that they need to consider having the injectable IM glucagon to actually try and give them that raise of glucose or intravenous glucose. And this sometimes needs to be administered by a paramedic or a third party. James, is there anything else you'd like to mention?
Yeah, so I think it's really important to remember to not only focus on the physical effects from hypoglycemia, but also the psychological impact. So 1 in 7 people living with type 1 diabetes actually live in fear or with a fear of hypoglycemia. And it can lead the person to sometimes run their glucose levels high as a coping mechanism, which that obviously increases the risk of complications in the long term. So fear of hypoglycemia is a state of fear which I too have experienced from living with type 1 diabetes myself. So my fear developed after I experienced a moderate episode where I had symptoms of confusion and dizziness. And during the episode itself, I felt quite vulnerable and thought that things would actually become quite severe. Thankfully, though, I was able to effectively self-treat the episode and recover. But the effects from the episode left me with a fear of experiencing further episodes, which I sadly still feel at times today. So in conclusion with that, it's really important to talk to the patient about their experiences of hypoglycemia to see if it has caused a psychological effect. And to help, there's a survey called the Hypoglycemia Fear Survey 2 or Worry Scale. And these are useful assessment tools that can help guide conversations and fears.
Thank you, James, for that very personal and insightful point. And I think that brings us nicely to a close. We hope you found this discussion useful, as well as the presentation and the anime. Thank you for listening. Goodbye.
Goodbye.